So we buried the X-Fix, now let's bury the DHS. All right. So I have no disclosures relevant to this talk other than I just want to make clear, DHS, when we say DHS, some people can refer to a specific implant by a specific company. Really the concept is sliding hip screw, and a sliding hip screw can be attached to a nail or a plate, doesn't matter. And so what we're really asking is, should we continue attaching sliding hip screws to plates? And let's face it, we're all nailers by now. This is a Brian Cunningham study from a few years ago. It shows basically 93% of the people submitting cases to the boards, 93% of their cases are nails for IT fractures. And there's a good reason for that. There's a good reason why we're nailing, right? It has a biomechanical advantage. So less lever arm, you have less cutout, less force on the screw. There is less room for shortening, so less shortening. Now, if you have, there's a biological advantage, which incision would you rather have on your hip? The one above or the one below? And finally, there's we typically say there's a cost advantage using DHS, but is it really? If you think there's a biomechanical advantage to nails, and you're going to have a biomechanical advantage, then even if you have, you save $1,000 on average per case of DHS, it's enough to have one biomechanical complication, one failure a year, and then you kind of wiped up all your savings, right? So what's the point in that? And then you add all of these catastrophic pictures that we all kind of seen in our career, and case closed, right? I should probably stop speaking right now, but as you know me, I can't, so. Let's go a little bit deeper into this subject. So let's start to understand the biomechanics first. So usually you begin by understanding the classification, and this is the new classification for IT fractures. And what they would have you do is classify these proximal femur fractures into 8 types, and then measure the lateral wall or lateral cortex here of the proximal femur. That's all important right now. That's how you determine is it a stable or unstable fracture pattern. But let me suggest a different way of looking at this. That's the way I look at the IT fractures. So let's just shift the femur in the way where the force of the joint is being applied to the proximal femur. And then if you have a simple fracture line like you see here, there's really 2 forces that are trying to act on it, right? It's trying to shorten and it's trying to fall into varus. But if it's a simple fracture line, there's no way it's going to, and you adequately reduce it, there's no way it's going to shorten, and there's no way it's going to fall into varus. It just physically can't fall into varus because it's bone-to-bone contact. And it doesn't matter what the size of your lateral wall at this point is, as long as it's a simple fracture line, one fracture line, you have bone-to-bone contact, it's not going to happen. Now, even if you add a tiny lesser troch fracture to that, you still have bone-to-bone contact. It's not going to fall into varus. It's not going to shorten. It just can't physically do that. Even if you have a slightly bigger lesser troch fracture. It's only when you start getting into this area of the screw or really sizable calcar fracture, then you start seeing this ability to fall into varus. And then, of course, if you have comminution, it's going to shorten because it's a no-brainer, right? If there's no bone-to-bone contact, then you will have it's going to shorten until it hits the implant, and you better have a nail in that case. And the reverse obliquity fractures just don't have anything to prevent this from shortening. It's just going to fall off plates and pull out all the screws. So there's no magic in this. It's just simple mechanics. So here's a case. You can see a tiny little lateral wall of the femur, and people will say, well, you can't put a DHS if you look at the new guidelines because it's so tiny. But you do an open reduction, you get bone-to-bone contact, do provisional fixation, and bam, you have a healed fracture with a DHS. So let's look about so that's the biomechanical side. Let's look at the biological advantage. And it's true, this is a big incision compared to your incisions for the nail. But when you look at your incisions, right, if you add the proximal incision for the nail, and then one for the hip screw and one for the interlocking screw, and you add them up, then you're not talking about such a big difference, especially if you're kind of making this initial incision a little bit bigger, as most people do. But more important than this, you're going to have to convince me that shoving a big drill into the abductors is more biological friendly than just elevating the vastus lateralis, which nobody actually knows what it does, but elevate it and then repairing it at the end of the case. That can't be more biologically friendly to the soft tissue. So I'm not sure about the biological advantage as well. Of course, you can combine the biological disadvantage of both approaches, and you can still get away with it with a very good result, because that's not the problem in these fractures. So what about the cost benefit? Well, you say, well, nails are maybe preventing these failures, and that's why it's advantageous to use nails. The only problem with this approach is that there is no proof. There's 20 years of randomized controlled trials that could not find any difference between the outcomes when you all comers treat with a plate versus all comers treat with a nail, if you choose the right fracture patterns. So if you are treating everybody, if you're a nailer, quote unquote, and you are treating everybody with a nail, you are incurring this cost disadvantage or the extra cost without getting extra results for your patients. Now, I imagine that I convinced about 0 people here to switch back to a DHS. And some of us will just continue doing nails. But if you do that, just remember that if you have a simple, stable fracture pattern and using a nail, you're actually making the case a little bit more difficult for yourself, and you have to be careful not to fall into this wedge phenomena when the nail actually displaces your reduction, and you may end up with this kind of reduction. But if you do, don't worry, take out the nail, do an open reduction, provisional fixation, and do a DHS. So I think we should keep it in our toolbox. Thank you.